you've done at your
Uh,
hospital. Because obviously I want to see that done, not just at UMass, but like
right,
everywhere. Um,
right, right.
so, I know I've sent you the questions, but
Yep.
we're just gonna have like just a conversation.
Yeah,
Um,
no problem. I'm gonna let you lead it. I mean, I tend to not be quiet, so I tend to speak a lot. So,
that's fine. Go
just
ahead and
it
tell
was
us everything. Well, you know what? Then we'll just get started then.
okay.
So tell us your name. Tell me about what you do. Go ahead.
Sure, sure. Yeah. So my name's Lee Steere. I'm been a registered nurse for about 27 years total. Prior nurse manager of a medical surgical unit, prior critical care experience in a level one trauma center. And I always had sort of this love for vascular access, and I don't think it started for the love of vascular access. It started just with the love of putting in IVs. Didn't even understand what vascular access was. And a job opened up down here at Hartford Hospital. I was actually living in Massachusetts at the time, and so I came down here and I interviewed. I actually interviewed in another area, an ICU in the hospital at the same time. And kind of interesting because the hospital at that point had just gone through a decentralization process. So they were a full team doing all the IVs, hanging antibiotics, giving all the blood, and they got decentralized and cut from a full team down to about 5 people. So interestingly, when I was interviewed, I always tell this story. I was interviewed, and the director, it was a director of IV therapy, and it was for 5 people, but she had clearly been here for a long time, and they weren't going to demote her because they were decentralizing. Because I think they also knew that she had one foot out the door, ready to retire. But she interviewed me, and at the end she said, "Are you sure you want to work here?" And I said, "Well, why wouldn't I? I mean, I interviewed." And she's like, "But you seem you seem like such a nice guy, and the morale here is so bad right now because everybody was just really mad." And I said, "You know what? It's fine. I really want to learn vascular access. I love putting in IVs, and I'll just come with a smile, and I'll try to be contagious, and hopefully, people can help change the morale." And so I got into it. About a year after, it was about actually 6 months after that, the director approached me, said, "Would you be interested in being a manager?" So I was the interim for 6 months. And after 1 year here, I became the manager. So I've been here for now almost 19 years. And it's been just a ride and a journey and an adventure, and one of just pure professional growth and pure growth in our vascular access team as we stand strong today at 32 team members. We took over control of all the IV insertions on the med and on the inpatient units, with the exception of ICU and labor and, well, not labor and delivery because that's outpatient, but they do get admitted. But we support every area greatly. Even our outpatient volume 1 year over the next went up like 75%. So with the growth of the team, we just keep expanding our services, which just it keeps allowing us to show that we have value being here, and we provide value to our patients. So it's been a wonderful ride, and I've learned so much in vascular access compared to what I used to know. If I had known if I had known back then what I know now,
Right.
I probably would have fallen in love with vascular access like immediately and wanted to get a job in it, because it's so different than what you're taught in nursing school.
Right.
Because you're taught so little about it, and nobody really knows. You taught about how to hang fluids, and sorry, I'm going to wait 1 second just for the sirens.
Okay.
uh,
It's okay.
um, you're taught about drip rates, you're taught about hanging meds, the five rights, all these things, but you're not taught really what is vascular access. So it's been a wonderful ride. So, anyways,
I just love hearing all of that because I resonate with that same
yeah,
sentiment. Like, I got into vascular access because I love doing IVs.
right,
And like, I didn't start out good, you know what I mean? But
right,
I got
right,
better, and it was all about that learning process. So I totally resonate with what you're saying.
good,
And I love to hear it. You talked about, changing the morale of the people around you. And I
right,
think that impacts the culture
sure,
of vascular access.
right,
We're not just doing the task of putting the IV in,
right,
it's like a specialty where we understand what we're doing. So,
right.
like, what are the strategies that you use to use with your team to really kind of just push that change in your hospital?
Yeah, so it took some time, and when I first started out, I was more or less just trying to get my feet wet, get comfortable, learn all the procedures that we perform, pick insertions, midlines, and obviously it was much, much different back then. Um, but I mean, a lot of me is just being positive, optimistic. I was at one point in time the manager not only of vascular access team, but I was also the manager of med surg unit. And that's where like I really couldn't spend much time doing vascular access. So I eventually finally convinced my administration to just let me grow vascular access because, it was really just kind of a department that was just there, and there were heavy delays with IV starts just because it wasn't expanding, it wasn't growing, it wasn't doing anything. And so basically like the strategies I utilize, we are a lean hospital, lean facility, so I do use the lean principles. We huddle every single morning in front of a board, and I let my staff come up with ideas, and it's just listening to their ideas, showing them that you're interested in it. We've done research, and I think that really makes people happy to know that like we're contributing to the standards. I always talk to my team about how we're viewed nationally as a very progressive IV team. I try to lots of recognition. I mean, this is a department. It's become a place where people want to come to work.
Yeah.
And which is really exciting to me because I know there's so many challenges out there, staffing shortages, we talk about the different generation of nurses coming in,
Yeah.
but people really are knocking on my door. The minute I get a posting, they're wanting to come here. We have a very strong employment engagement survey results. We're a tier 1 team, which means everybody's engaged, everybody wants to make a difference. We don't get me wrong. I mean, this isn't all rainbows, sunshine, and unicorns. We definitely have our challenges, but it's really being out there with your staff. I mean, I spend a lot of time here. I really engaged all team members on all 3 shifts, and just try to really make sure they recognize that we are valued in this organization. And part of what's helped me is I've developed a lot of really strong relationships here with other departments and disciplines. For example, a huge relationship with interventional radiology, to the point where if I call, they're going to do whatever, because they just trust us. I have a very strong our team has a very strong relationship with the IP folks. So that's a strong relationship, good collaboration. And most of the attendings, that have been here, they really do respect us. And that's just taking time, and I tell you, when it did require some removal of some of those nurses that were here when I first got here, because you can't change everybody. You can try to lead everybody. What do they say with the horses? You can lead them to the water, but you can't make them drink it.
Right.
And that's kind of what I try to do, is just bring them along with me. And some people are going to be gung-ho and 100% there, and some are not. And you just got to kind of tap into the strengths of those that are really full-blown interested, still recognizing the others for what they contribute. But it's really knowing your team, knowing your people, knowing what kind of makes them tick. And if you can inspire them and just keep them optimistic, good things happen. And it's so far whatever I'm doing, it seems to be working.
It's
So I'm very happy with that.
Speaking of what you've done there, can you tell us where you guys were before when you first got there in terms of insertions? You said you've now taken the responsibility of placing all the lines, which means your med surg nurses, your ER nurses, they're not placing the line. So
the ER nurses are, but we do support them. Yeah. So it's really the inpatient floors. Yeah. So when we first started, it was a 24/7 service. It was probably, I mean, there were some days there were only 2 people on days, 1 on evenings, 1 on nights. And,
how many beds?
867. So, but it was, it was different back then. Vascular access again was a different world. We were still giving a lot of IM injections, I think, and now everything's given IV, so there's
Right.
just so much more of a need. But yeah, so we were doing insertions just on an as needed basis. We did pick lines, but maybe with a success rate of like 70% at the bedside, and then the rest they just keep sending to IR.
Yeah.
So that's something I had to turn around because IR and IV didn't really have the best relationship in the beginning. So, I started to look at, well, why are we sending patients to IR? Or is it that we're not, trained? Are we not educated enough? So I tried to really, beef that up with the team and get them, more educated. We started scanning IJs because we didn't have Sherlock tip location. Because when I noticed that every pick we put on, all these picks and they would just go up the IJ, we get a chest X-ray and then we'd see it. We try to power flush it out. So then I was like, one day, well, let's put an ultrasound on there. There it was, and we'd power flush them out before we got the chest X-ray. So we eliminated a lot of IR trips. So that helped build up a relationship with them. We now probably do 99% of them at the bedside. We took on Dobhoff feeding tube insertions in the hospital. We took on through the research that we had done, really trying to find the perfect PIVC bundle for insertions. We did a research
Talk
study
about
on
the
that.
PIVC bundle that you do. Because I
Yeah,
read about it. Let's talk about it.
yeah, so that's the PIV5 rights where we use a proficient inserter. And I say inserter because it doesn't have to be a registered nurse. And, we can talk about that if you want, because I know that was one of your questions. And we are looking at that from a system perspective. But anyway, so right inserter, somebody who can use, ultrasound very proficiently. We make sure we use the right supplies. So we use an anti-reflux needleless connector from Nexus Medical, the TKO 6P.
I
We
know
use
about it.
antimicrobial dressing that contains pure chlorhexidine, no gluconate, and that's made by Entrotech Life Sciences. It's called the Prevahex. And then we just make sure, we're doing forearm placement, looking at the right vein to catheter ratio, smallest catheter possible. And really trying to find the good vessels, the cephalic or the basilic, and trying to avoid those collateral vessels that we just know are not going to last. So we do want to we want to keep our first success ratio above 90%. So every single team member has an ultrasound with them all day long. And we do. I think we're close. We're probably 90% or a little bit better. We were 96% in the study that we had conducted. But the study that we did with the PIV5 rights bundle, that was what gave me the ability to create a business case to present to my CFO and CNO so that we could justify taking over all IV insertions, which, was very interesting because my CNO really did not. The meeting was very short. It was only about 5 minutes. It was supposed to be 15 minutes, and it turned out to be 5 minutes. And all she had to do was see the pictures because the study that we had done, which was published in, I think it was Java 2019. But it was they had pictures of before. So what was the control group and what was the experimental group with the PIVC 5 rights bundle. And that's all she needed to see, because it just really just showed you, the art and the science of putting in IVs, and that, you can really make them look terrible, or you can really make them look like you're following the evidence and using best practice with your insertions. So
That's amazing. And I like that you could just show her the pictures, but how do you convince her about the money side of it? Because I know the better supplies cost more. So how
correct.
do you convince, the people that care about the money,
Right.
that, this is going to be cost effective? I know you brought a calculator to us.
Yeah.
So talk about that.
Yeah. So well, first of all, the study that we had done, it was, I believe it was about, I can't remember the exact number. It was over 200 patients. And the results that we showed was a 29% reduction in peripheral IV complications. We had a 96% first stick success ratio. We didn't have the first stick success of the control because it's just the way the study worked out, the design of it. So we used what the literature is, and it's at 33%. We also looked at dwell times. We had one of ours lasted, the longest was 333 hours, where the control was 111 hours. So a big difference there. And then we put a cost analysis to it, which I know is what you're talking about. And so what we looked at was we took two, I like to call them unemotional numbers. Okay, you can't massage them either way. They come out of a database, and that's what they are. So we took the number of admissions to the hospital, the number of catheters that we purchased as an organization, divided the number of admits into the number of catheters, and that determined our catheter per patient stay. Okay, so originally it was high at like 9.9, but then we massaged the numbers a bit to say, okay, well, if I had a vascular access team here and I covered the majority of the insertions when a patient comes to the hospital, so we took out like pre-op patients or patients in any outlying area that starts there but then gets admitted. So we took 75% of the admits, 75% of the catheters, and that gave us a 4.4 catheter per patient stay. But what we really took the money to was the savings in terms of nursing time. Ooh. Because nursing time, and today it's much more valuable than it was even back then. But with the amount of catheters that was being placed, if you took 20 minutes per insertion, it turned out to be close to 50,000 nursing hours spent annually putting in peripheral IVs. So then we took 20 minutes of the nursing time, kind of like an average salary for a registered nurse in the state of Connecticut. So we took 20 minutes of their time to the number of catheters that was inserted, and the cost of the supplies, to give us a number of about $4,700 per bed, or it was 4.4 million to insert all the catheters with nursing time. Okay, and then we took the beds and divided that 867 into the 4.4 million, which gave us our cost per bed of $4,700, 4,700, 4,800, around there. And then we took the results of the study, and since we had an 89% success rate from catheters lasting from the beginning to the end of therapy, we took that into account with our number of catheters inserted to the same number of admissions at 75%, and that gave us a catheter ratio of 1.1 per patient stay, which dropped the nursing hours, because you're putting much less catheters in, down to like 12,000. So even though the cost of the nurse went up, because nurses in the state of Connecticut who put IVs in and specialize in it get paid a little bit more, the cost of supplies went up because we're using better products. But because we were putting in so many less catheters based on the study results, it turned out that we were just spending over I think it was 1.4 million, whereas we ended up saving in the total of approximately 3,000 plus per bed. Now, everybody kind of wanted to argue with me on that, because they were saying, well, that's, are you really saving that? Because you're not firing nurses, right? You're still having them employed, as the hospital. I said, yes, but I'm giving you those nursing hours back so the nurses can pay more attention to, being at the bedside and, developing stronger relationships with patients. Working more on better assessment skills and better planning and implementing, and hopefully that will help reduce your length of stay, which is huge in administrators' eyes. And we also, if you really think about all the things that we've done ever since we've taken over, so yeah, maybe we didn't reduce the number of nursing hours, but we also took over all central line care and maintenance out of the ICU. We remove all CVCs outside of the ICU so we can get patients out of here faster. We took on a lot of more tasks that is obviously showing value to the organization. And that's really what it comes down to, is showing, how do you demonstrate value? Right. Because if you're not an asset to an organization, you're a liability, meaning you're not bringing in revenue, you're not showing constantly the data to say, this is what we're doing, this is how we're helping organizational goals, you will get cut. That's just the reality of the situation, so
Wow.
Told you I can talk.
No, but this is awesome because you're explaining the issues that are in most
Yeah.
hospitals that don't have teams like this. This is the approach that these hospitals need,
All right.
and I just think that you have done an incredible job
Thank you. Thank you.
um, in Connecticut and doing what you're doing. And I think it's something that's worth talking about because this is something that I think we can replicate. I don't think we need to reinvent the wheel. I think
No,
that
I don't think any of us
people
need to.
doing it,
I
if
think what we can do is learn from each other,
exactly.
because I am not, listen, I've been very blessed to be able to do what I've done here. But I would love to also learn from others. And I have learned a lot from others, by going to conferences, by working with our vendors, by looking at the, acceleration of good products, looking at the evidence, looking at best practice, following the standards, that's what has allowed me to be able to, grow this team and excel it. And clearly my passion as well. I mean, I'm very passionate about being a nurse. I'm very passionate about patient care. And that because that's why we're here. I mean, if there wasn't patients, we wouldn't have a job. So,
Right,
um,
exactly.
and there'll always be patients. So,
Exactly, there is. I'm going to pivot real quick. I
yeah,
want you to just touch on what you've done in terms of infection rates when it comes
yep,
to all lines you've
yep.
placed. Can you talk about how you've kind of grown that or
Yeah, I mean, the whole collab sees it's so multifactorial, so it's very difficult. We've had our ups and downs. There's no doubt about that. So what I always tell my team is this: you can only control what you can control. Okay. And we can't control every minute, every time a nurse touches that line. I can't tell you if the nurse is going to scrub for 15 seconds and let it dry for 15 seconds each time she's accessed,
yeah.
but we teach it, so we do every nurse that walks through the doors of Hartford Hospital as an employee has to go through a class with me. And it
Awesome.
touches on, CLABSIs, PIV care and maintenance, all that stuff. Anytime somebody's going from a med surg area to ICU or to step down, I also do education for them. Sometimes they're hearing the same thing I told them a long time ago, but
Worth it.
repetitiveness
I
works.
think it does.
This calendar year, so 2023, we started a competency day. Now that COVID has finally, calmed down, I want to say it went away, but it's really not. But so we started a competency day where people come to a station that we have, and we have lots of pictures, boards with catheters on them, just to try to again reinforce the content. We are out there constantly. So we do rounds on our central venous catheters constantly. So I can't say that we print up a new list of all the central lines in the hospital 3 days a week. And we really try to see as many as we can during those 3 days, advocating for removals, advocating for different devices, or advocating for them sometimes to stay because the patient doesn't have anything. I also bring in vendors. So Eliquis Medical, they're great in working. Sorry, Eliquis Healthcare. They're really good about coming in and helping me do CVC prevalence rounds. And it was like the last one we did. I mean, things just looked really good out there. There were 77% of our dressings were intact. None of them were fully detached or partially detached. So it was just edges lifting if we saw anything. And that just comes around to better education with mastocell application. So, and then making sure that we document all this, the other thing that I also do is I'm part of our patient care clinical value team that looks at all products coming into the facility. So being a member is great because it gives me that special little advantage of, being able to come in with products that I truly believe in. And it's, I look at products as so necessary in all of this. We couldn't do it without our manufacturers and our vendors. And I stress that anytime I speak. I do try to say, people go see them, say hi to them, talk to them, because they're yes, there are some that are a little bit on the gruffer side, but there are many out there who are willing to partner with us and try to, do better patient care. So it's, looking at the products, I really pay attention a lot to them. I don't jump right on, a new product that comes out because I want to see how it's going to function. So I do believe that, the products that we have chosen and I've been able to get through our CVT committee have really helped as well. So very, again, multifactorial, having good relationships with my IP folks is really important as well for CLABSI prevention. So, you can't control all of it, and not everybody agrees with the definition. And hopefully, it'll change. May not change for the better, may change for the worse, and we just have to accept what that is. But it's, again, knowing it and knowing where you can contribute to the prevention efforts is really the best you can do, unless you're literally the one providing all care and maintenance, all accessing, all everything, because multiple hands are going to touch those vascular access devices. So
It's true. I'm just so happy to hear everything that you're doing.
good.
My final question, because I don't want to keep you too much of your time, is describe your typical day as a nurse manager of a vascular access team.
Yeah, so I'm here pretty early, 7 a.m., sometimes a little bit earlier. And so because we do huddle at 7, and that's my night shift coming back and, giving off reports. So we do, we go over, do some recognition. We go over, any major hospital announcements that, has to pertain to everybody. Then we go over our daily playbook. So what do we have for staff? Who's going to do what, when and how? And then we go over our drivers. So our metrics. One of them's, how many lines did we get through when we have printed our list. So we're always trying to get above 75%. I think that's a pretty lofty number. We look at our productivity index, which is huge and very important. And that's looking at, productivity index, what contributes to that. That's all our CPT billable codes. So making sure my staff is charging appropriately. And then we also have built in, because there's not too many things we can bill for. So I had to make sure that we got a lot of credit for all the other things that we do that we can't bill for, such as, rounding on central venous catheters, to make sure that affects our productivity index, because we want to stay at 100%. I have 2 areas. I have an infusion center in this area. So obviously after here, I go to my infusion area and check in with them and make sure that everything's going well. And at times I have to get out there and do the work with them, which I'm very comfortable with doing. I try to stay more on the pick and midline side, only because if you don't sit there and place peripheral IVs with ultrasound consistently, you will lose the skill. Okay.
Yeah.
And unfortunately, but fortunate, I have built a very large team, so I don't have to go out as much. So, but unfortunately, that means I'm not keeping up as well as I'd like to with my skills. Attending meetings, obviously, that are valuable, HAI committees, multiple of them, CVT committees, just staying in touch with the team. How you guys doing? Where can I assist if need be? Making sure that I, always am available to them if they're struggling, trying to communicate or advocate for a patient. There's interviews, there's disciplining. I mean, there's no cookie cutter day. It's like you come in and sometimes you're like, okay, you have the best laid plans to get all this work done and you get none of it done,
Right.
But some of my best days are truly when I'm out there, and that's, at the bedside, talking to patients, even if it's, dealing with a complaint. I mean, I'm okay with that. It's just nice to be able to see them and try to, problem solve and troubleshoot things for them, So it's, and just, you got to be optimistic, follow our leadership behaviors, being in the moment, keeping myself accountable, looking in the mirror all the time, if things don't go well, did I, looking at my part, a lot of
Perfect.
self-reflecting, self-awareness.
Right? No,
It's a, it's a,
needed.
it's a, it's the tough job, you
Needed
know. It's
to continuously grow, to, look within, what could I have done better? All of those things.
yeah.
That's amazing. My
We,
actual last question. This is going to
oh
be
yeah,
my
go ahead, no,
talk
please.
about the type of certifications. I know you have your VABC, CRNI. What about your staff? Let's just
So my staff, so well, you have to work a couple of years, get your feet wet. So I do encourage after 2 years. I used to have it as 2 years, and then I was like, wait a minute,
we had that.
I'm being a little bit unrealistic because the test is only offered twice a year, right? So I decided to, let that be. But if somebody after like 3 or 4 years is not taking the test, I kind of will go up and nudge them a little bit and say, yeah, I think it's probably time now. So yeah, I do encourage VABC. I would love to be at 100%. The highest we've gotten is 65%. We are now at 43%, only because we keep growing. And so that's going to fluctuate that number. But I do definitely certification. I strongly encourage, I really try to get people to want to go to conferences in person because I think just the networking is just,
So invigorating.
it's incredible for me.
Yeah.
And I've gotten to know some great people in vascular access, Jack Ladon, Michelle DeVries. Um, I mean, I can go on and on with Matt Gibson. I mean, it's just great people out there who we all have the same goal, you
Right.
know. So I've left many people out of that. Obviously, I don't even know why I started using
Hey,
names, but
I
it's
feel like I know the people you're talking about.
yeah,
There's so many people. There's so
right,
many. I've been to
right,
2 conferences already, and I'm just like, there's so many amazing people
yeah,
doing
yeah.
great things with vascular access. Lee, thank you so much for
You're
doing this interview with me,
oh, you're so
for
welcome.
taking time, being patient with me.
Oh, I've always loved your enthusiasm. I really
Thank
have. So
you.
when you asked me to do this, I had no problems in
I'm
being like,
so excited.
absolutely.
I'm just
So
so excited to post this. I hope people
thank
have
you.
questions. I may
Good.
come back to you.
Please
Uh,
do. Please do.
Thank you so, so much again.
You're
I'll
very
let you
welcome.
go. Have a good day.
All right, you too.
All
Bye-bye,
right,
everybody.
bye.
Bye.
Awesome.